This is QD Clinic, and I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live, the original best hybrid meeting. This is going to be our third year. Hybrid meaning you get it your way. Stay home, watch it, or tune in, however you want to tune in, after the meeting, during the meeting, or come to Fort Worth. It's going to be a great meeting. Today, we're going to talk about my new and evolving, according to COVID, clinic routine. So at this point, and I've been doing this actually probably since June, I'm pretty much 50-50, meaning 50% of my clinic time is spent face-to-face clinic. The other 50% is doing telemedicine. So let's first talk about clinic days where I'm actually doing face-to-face patient care. I show up and the routine is the same, whether I'm going to the county hospital and doing clinic there, or whether I'm going to our private clinics. Before I actually enter the building, there's an inventory of symptoms, exposures, risks that I have to sign off on. I think it's a good idea. If you think you've been exposed, you have another measure of responsibility to mitigate that in some way. I am always subjected to a temperature check. You know, if my temperature is not 97.1, as it's been every day for like the last 6 months, there must be something wrong. But I'm remarkably consistent, at least as far as my temperature. So the rules are, patients are told that it's just going to be you in the exam room. Don't bring your family, don't bring the crowd, don't bring the congregation. There are pretty much no exceptions. It's you and the doctor in the room. The exceptions are elderly who need help and people who need help with communication. And we do make allowances for that because we want to practice physical distancing within the exam rooms. So that means I'm on this corner, they're in that corner. No one changes the chair where I want them to sit, and it has to be my way. That's to make them safe. From start to finish, when I'm in clinic, I'm wearing a mask. I'm wearing goggles, and when I'm in the room with the patient, if I'm going to examine them, I'm wearing gloves. So we maintain 6 feet. The virtual exam is done, meaning I don't need to do a hands-on. Seeing them, face to face is very important. I get to see them walk. I can actually see their whole body. I can see their body habitus. There's a lot of things I can get just by watching them, without necessarily touching them. But most patients, about half the patients who do face-to-face visits, I'm doing the virtual exam. You can see that on YouTube or on our channel, that I have a virtual video exam that really is very, very effective in assessing the patient and where they go. If I have to do the exam, I put on the gloves, slide over, do the exam as is needed. And if I'm going to do that exam, I'm going to do a full 28. If actually I do a full 66 joint exam, score a full 28, listen to the heart, lungs, whatever I need to do. And I think it's very restrictive, but still we accomplish all the benchmarks we need to do. Patients, there's no mingling with other patients. They have very limited time in the waiting room. They check in, they get their survey form, they're whisked right to the exam room, and they're going to be domiciled in that exam room until discharge, at which point they do an express checkout and they go out a separate door. Hence, there's really no interaction amongst patients with other patients. Again, I want to say to my patients, coming to the hospital, coming to the clinic, coming to get your blood drawn is an incredibly safe thing to do. What about when I'm doing virtual visits? Well, I don't need to check my temperature and I don't need to do the risk inventory the same way, but I do need to do Televideo telehealth visits, meaning that I refuse to do telephone visits. Telephone medicine is dangerous medicine. Again, you don't have enough tools at your disposal to make accurate assessments, and you're now relying on the ability of the patient to report to you about what's going on, which they're good at. But for instance, when it comes to swelling, nobody's good at reporting swelling. We have a tweet on that this week. The patient agreement between their reported swelling and physician-determined swelling, not good at all. The correlation coefficient is 0.2. So the sensitivity is good, but the specificity is really bad. So again, it has to be video, and you can actually see swollen joints on video. I want to do a full palpable exam in the future, but right now this is getting along really quite fine. So again, it has to be televideo. You know, there's some times when the video ain't working or the phone ain't working. Sometimes I'm doing a video exam and I'm using my cell phone to connect with them because for some reason their microphone ain't working or my microphone isn't working. That's the problem. So to do good televideo, you need a good setup. You need a Zoom room. We wrote about that last week. It's called Zoomatology. You know, you need a good camera. You need a good microphone. I'm actually using my cell phone making this recording right now. I have a ring illuminator. Let me use I'm actually going to change my glasses position, and you can see those little white lights. That's not the whites of my eyes. That's the ring illuminator that I bought for $30 on Amazon. I have a $30 microphone called FIFINE, FIFINE, $30. This is great. I have a little pop filter on there. This is as good as a $100 Yeti microphone. So lights, video source, good audio source, and control your background. You know, do you really want people looking over your shoulder and saying, my God, he's got a yellow skeleton in the background. There's a guitar over there. What's the artwork? I mean, no, a flat, boring background. So it's all about you and your interaction with the patient. My apologies for my background. So what else once you got the Zoom room set up, you need to set expectations with patients in video calls. Meaning sometimes they think this is a social call. It's like a telephone. Hey, how you doing? The Brooklyn hack. No, it's not that. This is a medical visit. Set expectations. Say, today we're going to cover blank, 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 blank. And, you know, whatever your expectations are, do not give the impression that this is a social call and that we're going to do this all the time, because then they're going to be upset when they get a bill, when you're billing at a 99215 or 214 or whatever coding that you're using here. You need to start by asking their permission. Can we do a video, televideo, telehealth call with you today? Is that okay with you? Yes. You need to document that you are in fact talking to the right patient. This is usually painfully obvious to you, but it doesn't hurt to ask their date of birth, what street they live on, their medical record number, whatever. 2 or 3 forms of identification are helpful. I usually tell my patients right from the start, we're going to cover meds and refills first. We're going to talk about any new diagnoses you have, and then we're going to get into your rheumatoid arthritis or whatever they're there for. So when you do your meds, get the refills done, queue it up, and you might modify at the end and then hit the send button, you're done. When you get a new diagnosis, write it down, put it at the end of your notes so you can address it in your problem list. And then begin with whatever you're going to collect. I am very keen on metrics. You can do a hack score, a pain score, and a global score, and over the phone even, or even by video, you could do a rapid 3 score and follow that as your metric going forward. I always collect data on what's most important to you, what your sleep is, what your activity is, what your exercise is. And then, you know, I like to sort of at some point, either in the beginning of the visit, you know, or at the end of the visit, ask them flat out, what can I do for you today? What do you most need from me? And then they'll give you the great list or the really horrible list, but, you know, you're working for them. So why not start that way or end that way? And then there's the bonus question. You know, give them the thing that they don't expect, depending on what they're talking about. They got a trip coming up. Tell them your tips about traveling. Tell them that it's okay to have their Enbrel out of the refrigerator at room temperature for 30 days with no problems. It will last. You know, give them what they need to hear. We need to talk about pregnancy. We need to talk about safety monitoring. We really need to talk about why you need to get that lab test every 3 months. You need to talk about who they should call when something goes wrong. Not your primary care, not your neighbor. You know who to call. Call Dr. Cush. I'm the guy that wrote that prescription. Again, it's a bonus thing that shows that you're sort of thinking about them. And sometimes that bonus that you deliver may have nothing to do with their medicine, their rheumatoid arthritis, but really what's going on in their life. And you're going to give good life advice. Of course, these days, the big bonus thing is I tell them, I want you to know, you're not immunosuppressed. You're not taking immunosuppressives. That applies to almost all my patients. That takes a tremendous burden of worry off of them. Now, I also tell them, however, when it comes to getting the COVID vaccine, You jump up and down and say, I'm immunosuppressed, I got rheumatoid, I got psoriatic arthritis, I'm taking biologics and methotrexate, and I think they're immunosuppressed. So let them play that card when they need to play that card. You support them in that way, but they need to know from you, the expert, that they are not at any grave risk for the disasters of COVID just because they're seeing you for the rheumatic diagnosis. There are some of our patients who are very immunosuppressed because they're on high dose steroids. They're actually on cytotoxics. They have other immunosuppressive conditions. But the vast majority of your patients, Behçet's, psoriatics, spondyloarthritis, rheumatoid, fibromyalgia, osteoarthritis, gout, etc., it's all not immunosuppression. So make that clear to them. That could be your big bonus. That's it for QD Clinic. Tune in tomorrow for another good one.